Morning. So, welcome. Well, it's really a real pleasure to welcome you to this session, which I think is the third time that we've done this. So this is an ethics session which we did at the last two IPIC meetings, and which has proved, I think, to be really very popular and is very relevant to our everyday practice, because we see a lot of cases and they're not always straightforward. They throw up all kinds of issues which are sometimes quite difficult to deal with, which require a lot of thinking and discussion amongst MDTs and the various teams, and also with families and the patients as well. So what we have actually are three real-life cases. So these are cases that are presented to members of the IPIC Medical Advisory Panel, and they've thrown up a whole series of issues that we want to discuss. And we're very lucky to have 6 eminent members of the panel here to be able to give their opinions and what how they feel about these cases and how they would take these forward. 5 of them or 4, I think, are practicing clinicians. We also have John from the who's patient advocacy, and also James Taylor as well. And what I'll do first of all is I'll just ask the panel members to introduce themselves and their affiliations. So if we can just start at the beginning with Dorothea.
Hello, my name is Dorothea of Grosse-Kreul. I'm the Senior Specialist Nurse for Allergy and Immunology at King's College Hospital, and I'm also the Vice President to IMID. Because my name is so complicated, everybody calls me Theo, which makes it much, much easier.
I'm John Seymour. I serve on the board of IPIC, and in that role, I'm a father and a spouse of PI patients. But in my day job, I teach at the university in family therapy, where I work with families with chronic illness.
I'm Nahla Erwa. I'm a clinical immunologist from Sudan, currently the ASIC president. I am affiliated to the University of Khartoum in Sudan, and I'm currently also the chairperson for the Clinical Immunology Specialty Council. Really delighted to be here with this eminent board of colleagues. Thank you.
Hello, I'm Alain Fischer. I'm a clinical pediatric immunologist at Necker-Enfants-Malades University Hospital in Paris.
Hi, my name is Steve Holland, and I'm an infectious disease specialist, and I work at the National Institutes of Health in Washington, D.C.
I'm James Taylor, and I'm a philosopher, as you can tell by the beard, and I'm employed by the College of New Jersey, where I must say I don't teach anything, but I try to encourage learning.
James's role is just to tell us how warped our thinking is when we've given all of these answers. So he just kind of sets us back on some kind of moral ground, ethical ground. Okay, so as I say, what I'll do first of all is I'll go through the cases. I'll ask the panel for their opinions. We'll ask James for how we've thought about this from an ethical, philosophical perspective. And we'll also then, we really would like you to participate in this as well. So there are microphones at the front and also at the back as well. So please just kind of join in the spirit of this discussion, and your opinions, your views are as welcome as our panelists. So thank you very much. All right, let's start. So this is case number 1. So this is a child who's the family where the child has a genetic disorder. One of the patients is a carrier, and the condition is inherited in an autosomal dominant manner. The child has a severe disease and has been through a bone marrow transplant, but unfortunately has a less than good outcome with complications and a not particularly well-functioning bone marrow. They're now expecting their second child, and prenatal tests have shown that the child has the same gene mutation. The mother is pregnant at week 22. Now, this disease has variable penetrance and can either be very mild or very severe. And the experience is that only 5% of children will be severely diseased, and the rest can be managed conservatively. And the parents want to terminate the pregnancy because of their experience with the first child. So the issue is around, how diseased this child will be. And so the discussion points we asked for the panelists is how best to advise these parents. What is the physician's role in advising the parents about abortion, even though there is only a 5% chance that the child will be severely affected, according to the data that is available? Okay, so I'll start the discussion from the panelists. So, Theo, if you would like to start the discussion, please. No getting away from it now.
That is a difficult one. I would be very concerned for the parents, because if they make the decision to abort the child and then later on have regrets that the child might have been better and might have been a mild version of the disease, how are they going to cope with that? So it would be a lot of counselling involved to make sure that they know very well that the 5% chance is low risk, however it can occur, and they would have a similar experience. So there would be, if they have the same experience again, it would be devastating to the parents as well. So it would be well thought about, and I would get more members of the multidisciplinary team involved and the psychologist involved.
Okay, thank you very much. John.
Well, I would reinforce that I think that the parents are the first focus here. They have the most data of anyone mentioned from the team and otherwise. They have years of experience living with this condition and caring for someone, and also having the experience that of exactly what the most difficult outcomes can be. And I think any discussion should start there.
Okay, thank you.
I think it's, I'd go for everything that has already been said, but I think what I'm going to do is I'll ask them for all the paperwork that they had from previous experience and ask them to come next week. It is a difficult situation from our perspective back home, because legally abortion is not allowed if there is treatment for the disease in perspective. So my counseling would probably include that, but it will also include that this treatment is not available where we are, so we have to think about alternatives very early and make arrangements maybe.
Alain? Yes.
Well, first of all, I think this is very well understandable that the family, that parents who underwent bad outcome for the treatment of one of their children do not want to have a second bad experience. Having said that, there is something which is weird in this case. This is the fact that the situation is where the mother is pregnant in week 22. One
Yes.
would have expected that the situation
Yes.
would have been detected much earlier at the stage where it's always difficult and delicate, but it would be easier if it would have, well, of course, could have been pre-pregnancy and at least much earlier during pregnancy. But the fact that it occurs at week 22 means that the level of information and conception of the family about the problem is not fully accurate. Of course, we don't know the reason why it is as it is. So, which means that there is our roles as physicians in this case would be to make sure that the family is aware of absolutely all of the considerations about this very delicate situation and this decision. Now, eventually, my opinion would be, once the family is very well informed with several, it has to be done quickly, but with several talks with different people, probably I would offer the family the possibility to go ahead, if they wish so, for abortion, knowing that in France, I mean, it would be in a grey zone, but it probably would be feasible to do it.
Yeah, okay. Steve.
I echo all of the previous concerns. The two sort of things that I'm trying to understand, it's clear that the first case had a bone marrow transplant that was not fully successful. And sometimes one can go back and figure out why it wasn't fully successful. I assume that people think that this disorder could be successfully transplanted, and so one might want to think why that didn't work very well the first time. The second thing is that for the parents' sake, although we talk about what the likelihood of a severe form of the disease is, 5%, and that means that 95% have a mild course, I'm still concerned that we don't really know very much in most diseases about what are the background genetic factors that make one person do well and one person do badly. And so the likelihood within that family, if we think that it's largely a genetic condition, they likely have more than a 5% risk. And so I would certainly be sympathetic to their concerns. The point Alain makes, week 22 is very late for a family with a known disorder to be coming to attention. So there may be other factors going on that we've not taken into account, and I think the legal realities in many of our countries about what can actually be done at week 22 are going to be quite critical. So while we might look to do what they want, we might also be preparing to do what may happen. And that would be to look into what would make bone marrow transplantation more successful and how we could try and make this work out better.
James, before you say anything, there's one thing that hasn't been mentioned. What are the rights of the child here? What are the rights here? This is a 22-week gestation infant. What are the rights of the child? Would anyone like to address that? Steve? Would you like to just, what are the rights?
Are you talking to me?
Yeah, what are the rights of the child here?
What are the rights of the child?
Yeah.
Well, this is a very controversial topic in the United States.
Yeah.
That question varies from state to state. I think many of us would say that the child, until the time of birth, has no intrinsic rights, and this becomes a very difficult point, and on this hinges much of the debate around abortion access in the United States. But I think in many states, the child does not have rights until it is born, and so I would continue at this point to pursue it in that way. At 22 weeks, and again, this is where philosophy and law are not always in accord.
Sure.
And so in the United States, we have 50 laws, and we have to try and figure out, 51, how to sort those out.
Okay, anyone else want to offer, just before I get to James, anyone else want to offer an opinion on that particular point and the rights of the child? Okay. No, I just wondered if anyone else wants to venture any other opinions or thoughts. Okay, in which case, James, would you like to offer your view?
So I'm a moral philosopher, not a bioethicist. You might have had experience with bioethicists who come in and try to tell you what to do. I'm not that person. But I did notice that my fellow panel members, when Bobby asked about abortion and the rights of a child, everybody did what everybody always does when this topic comes up. They look like they've just been handed a live rattlesnake, and you're not quite sure what to do with it, but you know you don't want to touch it very carefully. So I'm going to pull together the views of a panel, which I largely agree with, and then I'm going to do what moral philosophers are good at, which is making myself very unpopular by offering some more considerations that might throw something of a wrench into the works. So I think that Theo, John, Nahla, and others are all right, but this decision is going to be, in the end, it's going to be a decision that the parents need to make. But I take it that the ethical concern that we have to have, or the ethical concern that we're focusing on, is what role does the physician have in talking through the possible options that they all have with respect to this particular unfortunate situation. And as Bobby brought up the question of the rights of a child, I'm going to pursue that also. And I think that Steve is right, that, as is Nahla, but there's going to be legal implications. And those will vary jurisdiction to jurisdiction. As a philosopher, I'm not going to address the legal implications, mainly because I don't know what they are, and also I'm not really trained in that. I'm going to focus on the moral question of how exactly are the parents looking at the children that they're having. So we could imagine this situation. The parents wish to have a child who either might not be affected by the disease. And in that case, after the child with which they are currently pregnant, they might try again for another. And my question here would be, are they really viewing children in the right way, if that's how they look at them? Are they going to, as it were, keep rolling the dice until they get one which they are happy with? So my first question might be to talk with the parents about how they view possible future pregnancies. Are they going to pursue abortions in each case? Are they going to stop trying for a child? Or are they going to, as it were, keep going? And if they're going to keep going, how are they viewing children in that particular situation? I think that once we've talked about that issue, which is going to draw into questions of the rights of a child and the potential and the future of the children, we also need to make sure that the parents are thoroughly well informed about the actual facts of the matter. And there I think that Steve's observation concerning the possible background genetics might play a very prominent role. But the parents need to know, are they more at risk than other parents with this particular abnormality? Or is it that we just look at the statistical probability of the likelihood that they'll have further children with the same defect? So I think we ought to educate the parents, both medically, and also address their views of what having children mean to them. Are we merely viewing children as being instrumental? And should we take into account the possible quality of life of a child that they are currently pregnant with? If it is a treatable disease, shouldn't we allow the child the possibility of having an acceptable quality of life and going forward without an abortion?
Thank you,
Now
James.
I've made myself happily unpopular with everybody.
So I'm just going to pick up on that other point, that point you made is, let's say the parents go ahead with this particular termination, and they get pregnant again, and the child has the same diagnosis in utero the next time round. How do you advise them at that situation, that they go ahead and abort the child? Remember, this child has this disease has a 5% chance of having a very severe abnormality. By the law of chances, this next child should have a much better outcome. How do we counsel in that situation? So now we're talking about the next child, not this one, but the following pregnancy, where the child again has the same mutation. John?
Well, Bobby, if I can, I'm going to combine a message for both of those children, both the one you're speaking of in the future as well as the one we're contemplating now, the parent's decision. In both of those cases, I think it's what's been suggested about backing up, taking one, tell them to come back in a day or a few days to really understand the history of what has happened to this child, the first child, and his care and his diagnosis and his treatment and his failure to respond to expected treatments, and the parents' experience of that, and then some details around why is this just being identified in week 22.
Yeah.
There could be geographically, culturally, many different reasons, and some being very easy to understand and support, others that might hint at this child as object rather than potential person, and that's something that could be clarified with some of this extra time that's mentioned here by.
It might also be that the family were reluctant to entertain the thought that this child might be affected, and only came to a diagnosis very late in the pregnancy because either they were scared or so traumatized by what happened previously and were not prepared to face the possibility that this next child might be affected as well.
I would just reinforce that's very possible, because I certainly work with families where parents, even several years into the child's life, have still not gone through the diagnostics.
Yeah.
You know, they're that fearful of finding out, and I think that's a very different.
Okay.
That's important information.
Okay. Any thoughts from the audience? So, yes, we have a few hands raised. Josie, before I get to you, I'm going to ask Stuart to, I think, Stuart, you had your hand raised. Yeah, Stuart Tangi. So Stuart's president of IUIS, by the way, and gave the talk yesterday. And so he knows all about genetic diagnoses, all kinds of different complications.
I'm just wondering, from the perspective of family, obviously one of the parents is a carrier. So I'm just wondering, how much does that influence the decision? Because presumably the parent is reasonably well, or falls into the 95% category. So from their own perspective and experience as advisors or consulting, how do you work that experience into the decision that the parents are going to make, given that they've got both ends of the spectrum, obviously a dreadful experience with the child, but the adult, well, it doesn't say that one of the parents has had a reasonably healthy life, presumably.
It's a very important point, because you've actually got two ends of the scenario. So you've got a parent who's actually, we assume, living a normal functioning life, and then you've got a very diseased individual who's had a bone marrow transplant, who's at the other end of the spectrum of the same disease. Alain?
Well, I think this is a very good point, Stu, obviously, but in my opinion, I think what is in the mind of the parents at the time of the question is not the situation of the father or the mother, I don't remember, but the situation of the child who underwent transplantation and who is not doing well. So I'm not sure they are very much concerned about the situation of the parent, although it could be a problem for the future, for sure. So I'm not sure that would have much an influence in the discussion. I think the issue is really about their perception of the risks associated with the disease, knowing the poor case or the poor outcome of their child. If I may add something, I think you asked the question about what about the next?
Yes.
Which is the next potential pregnancy. Of course, it remains very delicate, but by the way, if the situation now is much more clear for the parents, they have a better perception of the importance of the medical decision and all of the surrounding social and psychological aspects, it would be slightly easier. Maybe as a doctor and people involved in research, we should tell them that we will do everything we can to understand better the disease, to identify, for instance, modifier genes that would precise the prognosis in this family. That would help a lot if we can achieve that. Maybe not, but then we can explain to them that we can offer, if they wish, prenatal diagnosis, or even better in such a case, I guess, pre-implantatory diagnosis, which be a potential option if they wish to go ahead with prevention of occurrence of the disease.
Okay, great. Josie, there was a question there.
Yes, actually, I was just going to say that I think what these parents desperately need is genetic counselling. You know, it's all very well hearing it from the doctors, but they need to hear it from somebody else who's just one step away, and to really get down to what may be the possibilities for them in the future. And of course, the cell selection and you know, is or might be an option for any future children that they might want to have. But I think it is really important that they get to hear things from a slightly different person rather than the physicians that they are being treated.
Okay, thank you. James, I'm going to move on from this one, but I'm going to just one last word. In past sessions like this, you've talked about autonomy. And autonomy here, from my understanding, rests with the parent. So whatever we say, and whatever the situation, in the end, it's their decision. And all we can do in these is try and offer as much information, advice, kind of spectrum of what could happen here. But if they choose to abort this child, and if they choose to abort the next child and the next one after that, that is entirely their decision. Is that correct?
Can I just add
Sorry, Nahla, yes.
It's a very regional issue.
Okay, that's very important.
Yeah, so basically, this scenario has reminded me of a couple of scenarios where I have received parents with affected children who were well into their disease, who had previous children, and who these previous children were actually diagnosed elsewhere. And they came back from this elsewhere fully equipped with lots of incomplete information that led to the divorce of the family, who were actually dealing with a child who was affected at the time, which made decisions for them and for us a lot more complicated and difficult for the child themselves. So this is another area where, as you said, autonomy is important, and it has to focus on the whole family. I mean, as a wife and as a mother and as a doctor, facing a situation where you are dealing with a separated family and a sick child in between them, who are not given enough information to understand what the possibilities are and what the chances of treatment are, but then they were made to understand, or were put under the impression that they will never be able to conceive a healthy child in between them, and even if there's a child who is not healthy, they will not be treated. That led to a drastic social drama, or
So the correct information is everything in these kind of situations. So James, just final word before we move on to the next case.
So your question is, shouldn't the final decision, both with this child and with other future children, lie with the parents? I think that the answer must be yes. It should lie with the parents. But that's going to come, I think, with two caveats. So the first caveat is, I think that while the parents might have the right to decide whether or not to abort, it's possible for you to have the legal right to do something which is immoral. So we could still question the morality of their decision if we wish to do so. And that, of course, is assuming that this is also a legal possibility, which will vary. And the second caveat I have is, I think that in this sort of situation where the first child is severely diseased, we might like to be very proactive and follow Josie's advice, but do it in spades, as it were. So introduce them to parents who have children with a similar disease, with different mildness and severity, so that they can see the range of possibilities, to engage in proactive counselling prior to the next pregnancy, and to make sure that they have as much information as they could possibly have prior to the pregnancy actually taking place. Not to push them in any particular direction, but just so that they have all of the information that they might need to make a fully informed choice in the light of their own values.
Okay, thank you, James. Okay, thank you, everyone. Let's move on to the next case. So this is yes, and again, this is from a real life case from one of our physicians who received recently received a 9-year-old boy for a second opinion, and this individual had numerous problems. So cerebral palsy as a result of neonatal hypoxia, seizure attacks, recurrent respiratory infections, hypersecretion, bronchial obstruction, poor antibody deficiency, hyper IgE levels, multiple allergies, lack of response to bronchial dilators, antibiotics, and steroids. He uses several anticonvulsant drugs. His physician has proposed to start him on immunoglobulin replacement therapy to improve his quality of life, even though this might be palliative. But the health insurance company refused. The parents are willing to consider a legal action because they want the child to be on immunoglobulin replacement therapy. How does the physician now advise the parents? How much can the physician advocate for the starting of immunoglobulin replacement therapy? So, another very complicated case, a real-life case that one of the audience has been faced with. So, Theo, can I ask for your view here?
Well, I'm very lucky that I work within the NHS. it really depends. Would it ruin the parents? Would it completely ruin the parents? Would they take out a new mortgage? It would be, if it is palliative. However, it would help the child, and it would probably make the child feel much better. We do know from experience that giving immunoglobulins to anybody makes them feel better. So therefore, I think, yeah.
So I just want to let you know that the panel is seeing the questions for the first time. So they're seeing it just as you're seeing it. So we're getting an immediate...
Not by choice.
Okay. So please, just carry on. You were saying...
I think there are two dimensions to me. One is the financial cost. One is are they actually really, would I be able to pay 14,000, it would be pounds, I don't know how much it would be in dollars.
Who's your responsibility to here?
It's the child, it's the patient. So
Okay.
I would do the best for the patient, I would advocate for the patient, and if the best decision for the patient is, if it's to have the immunoglobulin, I would advocate for the immunoglobulins.
Even though this might be a useless cause, even though 6 months later this child is going to succumb to other problems, and this is only just one minor aspect of his entire physical well-being.
That is my problem.
Okay,
That is
John.
exactly my problem, because I would think the other side of the coin would be, is this really going to do the best? Having immunoglobulins isn't easy either.
Okay.
And I would need to do a risk-benefits ratio. What is the best for the patient?
Okay, John.
Well, I think what both of these cases have in common is part of the professional's responsibility is to make sure that the parents are in the best possible spot to make the best possible decision. And that includes not only all of the data, but it includes helping to evaluate their relationship and help them to make the best decision that they can live with, 5 years out. I would want to do that before urging them into any direction, because...
Let me just start on this one.
Yeah.
Here it's not quite about the parents. It's about whether you advocate for the child to receive immunoglobulin replacement therapy against the kind of insurance firm, etc. So what do you advocate for as a physician? Do you think this is the right thing to do for this particular child? And the parents will obviously follow what your advice might be. So this isn't necessarily the parents' choice. This is they're looking for your opinion as to whether they should go ahead and kind of start, make a case for the child having replacement.
Well,
do you think this is the right thing to do for the child?
Let me shift from the professional hat to be the parent hat on this one.
Okay.
And say the terrible stress of a family member who is faced with the decision of, do you want to do everything possible to help your child? And that's often how these choices are put. So parents are in a bind of, well, of course I want to do everything possible, but at some point the cost even to this child of care. And as a parent who, yes, personal story, stuck bologna in my ears to let the dog eat it out of my ears so that my 4-year-old could start an IVIG for her primary immune. That's what parents are facing in caring, and to really think that this is palliative care. I've not seen children take to this in any form very well. And so what would they be gaining? This seems very difficult for the child and the parents.
Okay.
But that's the parent talking now.
Okay, Nahla.
I prefer to talk as a parent as well.
You can talk in whichever way you like. Okay.
Yeah. I think the order of the case itself wasn't very clear to me, but I presume that this is a second opinion. Is it?
So it's a second opinion. So it's come to you.
Okay. The first thing that I would do clinically is definitely reviewing the decision for the need for immunoglobulins, and then counsel the patients on facts about the presentation and the need.
So let's just say that there is a true antibody deficiency. This child is not making any antibody, amongst all the other complications that the child has. So, you could objectively say, regardless of the other problems, that there is an antibody deficiency. So there is a possibility the child would respond to antibody replacement.
Yeah. I mean, at this stage, I would definitely stick to my professional opinion and give as much information as possible about the different sides of the story. So the clinical presentation, the possible benefits of taking immunoglobulins versus the...
Would you recommend that the child goes on immunoglobulin replacement therapy?
It is a difficult one. I mean, I wouldn't write from just looking at all this. Right.
Okay, so just very quickly, in the context of all of the other problems that this child has, would you recommend that the child goes on immunoglobulin?
If it's the only thing that's left for me to do, yes, I would.
Okay, Alain.
So, assuming the indication is there, which seems to be the case, antibody deficiency plus recurrent lung infections, the right of the child is to get the best possible supportive care, and this includes immunoglobulins. So for me, I don't see here a difficult decision to take or difficult advice to give. This child should receive the immunoglobulins, for my opinion. Then, of course, comes the next step is how to make sure that the patient will get the immunoglobulins, given the fact that the health insurance company doesn't want it. So I would try to talk to them, to the company, and try to explain to them why this is justified. Actually, I would be surprised, maybe a bit naive, but I would be surprised that at the end of the day, once accurate explanation would have been given, that there will still be a refusal.
Okay,
but so let's go to the worst scenario, that even at that stage, the company still refuses. I will go ahead with the parents to help them, to advocate, to support them and support their decision, up to going to a legal action if at such a level of a refusal.
So you're purely saying that this child should get immunoglobulin replacement therapy, regardless of all of the other issues that the child is failing, is the short lifespan potentially.
Yes, because this is his quality of life.
Okay, all right, okay. So, Steve.
Yeah, well, I mean, if you are going to tell us that he really has a serious antibody deficiency, I don't see an argument point. The question about what does palliative care mean, where I come from, everybody eventually dies. So everything we do is palliative. Whether it is cholesterol therapy or blood pressure management, everything is a palliative therapy. So I don't see this as being different. And adding immune globulin to somebody who has recurrent infections who doesn't have antibody, this is a no-brainer.
Okay, James, again, before we come to you, I'm just going to throw in another kind of element into this, and that is at a kind of, so you've talked about the kind of clinical aspects. Okay, you've seen all of the other problems. The child just has a pure antibody deficiency. You're going to treat the antibody deficiency because that's the best thing for the child. Okay, let's talk now about the fact that you're dealing up against a kind of, the cost of this treatment and in a resource-constrained world. Do you advocate for this? So for this child's immunoglobulin replacement therapy is going to cost a certain amount. The child is probably going to have a very short period of life, even if he's on that immunoglobulin replacement therapy. And what does this health system afford? Could this money not be used for other individuals? So do you think about the wider economic aspects of this? Is your responsibility this could be of benefit to other children who may not get resources because money is being spent on this particular child. So where does your responsibility to the body of patients or to this particular individual? We'll go back the other way. So you start, Stephen, we'll go. So Thea, yes, okay, yeah. You start.
Well, that would be thinking of the NHS from my point of view. Within the NHS, you would think, do I give this child the care and therefore have the money spent on this child, which could go to somebody else, which sometimes is the discussion of NHS England with regards to certain drugs when they are quite expensive and quite dear. But I think it's a very hard decision. This is the child I'm caring for at the moment, and the nurse in me would like to do the best for the child which is in front of me. And I would find it very difficult to say, for the greater good, this child who's got a true antibody deficiency, who might have actually much better 6 months being on the treatment than it would have of the treatment not to give the immunoglobulins.
Okay. John.
I guess I am still stuck, having worked with many families presented with these extreme measure decisions.
Yeah.
And when is enough enough?
Okay.
When not being a physician, but reading through the list of complications, and I translate that into what kind of 24/7 care the family provides and has provided, it seems like being the non-physician on the panel, it seems like gamma globulin is like the smallest thing that is needed right now, rather than the most urgent that deserves this push. And coming back to my first statement, and having this family really believe and be ready to spend their last minute fighting the insurance company rather than being with their child.
Yes. Okay.
That's
a very important.
That is
a very important perspective.
Very serious ethical decision to me. What does this child need at this point? And to energize these parents into pushing a legal case, thinking that is going to have.
Yeah.
What are their expectations? It may be ethically correct from a medical perspective. This test says do this thing.
Yeah.
But this is a.
It's a very important perspective.
Yeah. It's not nearly as clear cut to a parent or to a family therapist who'd be advising a family as to should we do everything possible.
Okay. Very good.
Not clear.
Nahla.
Again, I'm going to reflect from what we tend to have back home. I mean, immunoglobulin is not insured. And when I read the whole scenario, obviously coming back from where I was kind of perplexed by the whole situation, because I was definitely thinking about the cost of the treatment.
Yes.
The parents would probably not be able to afford that, and what usually tends to happen is that we as doctors kind of initiate a chain of sourcing donations to fund the immunoglobulins. So the question of whether we should be thinking about the whole economic
so this becomes very relevant.
Is kind of even more complicated in my case, because I can take it as a challenge to the government that, we have very seriously sick children who have missed out on treatment all these years, and perhaps they have not been identified and they are not being treated, and now we are to the point where we have to think about the most expensive things to give them as palliative, which I don't know. I mean,
so in your situation,
in
your situation where you're resource constrained, do you put your efforts, energy, advocacy for this child, or do you do it for a child who may have, a longer outcome or more kind of complete correction of their problems?
As I said, what I would definitely do is just put the family in a situation where they can make a decision for themselves, considering the whole situation as parents and as parents of a very sick child, and consider the chances. If they made the decision and they really want to go ahead with the immunoglobulins, I would back it.
Okay, all right. And then, so, Alain.
Of course, the discussion is... discussion is not the same as a function of the socio-economical environment, that's for sure. So I will consider it in the context of the privileged context I am living in. So in that context, for me, the priority, without any, I think, possible discussion, is the right of the child to get the best possible support. He is deserving to have the best possible life, even if his life is extremely complicated, and even if his life may be only there for a few months or years, I don't know. So I think this is the priority, and this should go beyond any other aspects. So I would do again.
So you take a very clear view. This is about this child, regardless of how long he might live for. You think he should have the best quality of life, and therefore you'd advocate for immunoglobulin replacement.
By the way, on the economical point of view, I think the immunoglobulins would be a small part of the cost of his treatment, whatever, given his situation. And if we want to discuss about the economy of healthcare, then we have to consider now at a global level the cost of innovative treatments and so on and so on. So I will not take that into consideration.
Okay.
Well, I think it's very difficult for the physician who's dealing with a patient to put themselves in the position of how does that patient affect all of healthcare.
Okay.
Now, there might be times when you are in that position, but most of us are not.
Yeah.
Most of us are dealing with a patient, and our obligation is to the patient, not to the nation, not to the system, not to the hospital, not to the insurer. Our pact is with the patient, period. Now, the decision about whether immunoglobulin is really going to help him, that's a different decision. If you say it's really an antibody deficiency, you know, we think that immunoglobulins help there. There are other ways to manage those problems. If you're seeing this as a second opinion, and their primary doctor has said, I really think you should do this, and now they're asking you, should they take legal action against the insurer? Well, you know, I could support that very easily. But putting ourselves in the position of deciding who should ration what to whom, I think is extraordinarily dangerous and beyond what the patient thought they were getting when they walked in the door.
Okay. And just quickly, in your response to what John said about the fact that the family are dealing with so many other things, and should they be concentrating on immunoglobulin replacement therapy when there are so many other issues surrounding this family?
So I guess that's where it depends on what exactly you think is going on. If this patient has recurrent infections, and many of the things that you've listed there are going to be secondary to respiratory infections. If you think that the respiratory infections are antibody dependent and that you could replace the antibodies and reduce the respiratory infections, that would reduce the bronchorrhea, reduce the bronchodilators, the need for antibiotics and steroids. I mean, that could be a transformative intervention.
Okay.
So I can't tell, of course, without having seen the case, but nothing that you've said so far makes me think that the argument to not give it is a wise one.
Okay, great. I will come to the audience in a second. I'm just going to give James an opportunity.
So, I think that I agree with my fellow panelists, especially Steve's last point concerning the duty of physicians. But the physician's ethical duty is primarily, perhaps exclusively, to the patients that they are treating, and they need to advocate for those patients as strongly as they possibly can. But I think that there's a catch. The reason why I would say that a physician or a healthcare professional has the duty to advocate for his or her patients is in part because that, as Steve noted, is the pact that they have with patients, that you are my patient, you are my first responsibility. But it's also because a physician really can't see the range of patients. A physician might see her patients or the patients within her medical group, but she doesn't see all of the patients nationally or regionally. So she's really not in a position to be making decisions about who should receive which type of treatment. So that, I think, supports the approach that many of the panelists have taken. But I think that there's a worry that I would have about this, because it seems that the duty of the physician and the healthcare professional is to lobby for their patients. But they are lobbying to a body, in this case, an insurance company, or perhaps to a government insurance agency, who does see a much wider range of patients and is making decisions who receives which treatment on the basis of a range of patients that they see and the reports and requests that they receive from healthcare professionals. So this, I think, is a very difficult situation because the physician in this case has proposed to start the immunoglobulin replacement therapy, and I think that is clearly the right thing for a physician to advocate for ethically. But then they've received the information that, given what the insurance company has seen as a whole, this might not be a good use of resources, given that, as Bobby noted, everybody lives in a situation of constrained resources. So now the question is, does the physician go further and advocate more for the patient? They've already advocated initially, proposing the treatment, submitting the paperwork and so forth. Do they take the extra step and advocate more? And that I'm not clear about. Because my concern might be something like this. It's going to be John's concern, but from a healthcare perspective. But now a physician might be using their precious resource of time to advocate for particular patients, and that's going to take them away from treating other patients. This is the equivalent of John's concern about the parents taking time away from a child to pursue stressful and expensive legal actions. So I'm not sure what the ethical duty of the physician might be here. And I might also be worried that well-connected patients, middle-class patients who have access to attorneys and who know how to work their way through the system, might, if physicians take on additional lobbying on behalf of their patients, it might be the case that better connected patients and better connected patients' families are now receiving a disproportionate and perhaps unfair level of treatment and care simply because they have a privileged position that they're able to exploit. So I think this is an extremely difficult question, and I think that at best we should focus on the health of the patient first, but also we should recognize that this is going to affect the health of other patients also.
Okay. Okay, a question. So, Roberta at the front there. Could we get the... Yeah.
Well, I think that here in this point of access to treatment, patients' organizations play an important role. And I think that our main objective is to help the families to access to treatment. And we know the way how to do it and how to fight. The most important thing we do every day is educate patients and family. So I think we have to work together and to try to help to get their treatment. And
again, if I can ask you, but you might be faced with many patients who want the same thing. And does this child's other problems affect that choice? I mean, you may not have the resources to be able to support all of the different patients.
We have to fight that the child needs, if the child needs and the doctor prescribe the immunoglobulins, I will do my best.
Okay, all right. Other thoughts, comments from any? There's one right, is it Klaus? Yes. Hi, Klaus.
So thank you very much. I think this is a situation, even so it is not as complicated as it looks like here, but this is often what we face. And I totally agree with what has been said. If we come to the conclusion as a treating physician that it's important that this child becomes the chance of immunoglobulins because of the cause of the underlying disease, I think we should do everything that this child will get immunoglobulins. And for me personally, whether it's a palliative situation or not is secondary. I don't think that is important. If it really improves life quality of that last months of that child, I think it's worth doing it. What our solution usually is, we write, and I totally agree with what I said, I think we should avoid the legal fight. I think it will be stressful for everyone participating. And my experience is, if we tell the insurance that we apply for a 6-month trial of immunoglobulins, they're usually very happy to accept that. And saying then, okay, this is possible, we do it for 6 months, we reevaluate whether that is truly basically, often we don't know whether the immunoglobulins will improve it. But if we see that 6-month period will do the change, then we will go forth and say, this is really helpful to the situation of that child. And I would definitely support the parents in getting this support. If it's not helpful, and I think it needs to be very clearly discussed with the parents in advance so that it's a clear expectation, what will be done, I think it's also okay to stop it and then save resources for others. And I think that is what often happens in our situation.
Okay. All right, I think we're going to have to stop that one. Stop that one there, because we've got one more case to discuss, and we've just got just over 15 minutes left. So thank you again. So this is another real-life case. So this was, again, sent in by one of our physicians. Recently, I saw a 13-month-old boy who was referred for a second opinion with a potential diagnosis of Wiskott-Aldrich syndrome. A gene sequencing panel has shown a variant of unknown significance in the WAS gene. However, it was very likely to be pathogenic, and the clinical and immunological phenotype was that of Wiskott-Aldrich syndrome. The parents had done a tour of a European country already, and each physician had advised for transplant. However, the father kept refusing, as he said it was not proven that his boy had Wiskott-Aldrich syndrome because the variant was called a variant of unknown significance and was never reported. And he had 2 10 out of 10 unrelated donors, and that became clear as the physician received the total file. The physician offered to do a functional validation in parallel with the transplant workup, but the family didn't show up for a follow-up appointment. Now, this physician contacted colleagues in specialist countries, in specialist centers around that country, and made sure we kept each other posted on the initiatives to transplant the boy or to contact childcare. So this family has kind of disappeared, as it were, from the specialist care centers. There is a potential diagnosis of Wiskott-Aldrich syndrome. There's a clinical phenotype of Wiskott-Aldrich syndrome. There are unrelated donors available. So what is the duty of the specialist in this scenario? Okay, so Theo, do you want me to start with Steve this time? Okay, so Steve, well, let's start with you on this occasion.
Start with the specialist, yes. So I think this is, this case is very similar to the first case in some ways. You have a family that is seeking out advice, but not necessarily taking it. And this question about what is your responsibility as the specialist to the family and to the child. In this case, it's a born child, but the same sort of question. The family has one approach, you have another, and this is very, very difficult. And I think this gets to really now, you know, we're caught in this very odd world in which we now are focused on the genetics, appropriately so.
Yep.
And we say, well, it's a variant of unknown significance. And that word, unknown or uncertain, can be very difficult for families who are desperate to not have a bad problem. And I think my own advice here, and I think what I would try to do, is to spend some time sitting down with the family and say, you know, you're touring Europe, and you're going to all these centers. I'm sure they didn't see Alain yet, but you've gone to all of these centers. Why is it that you keep going but aren't listening? And I think that must mean that they're desperately afraid of something.
Okay.
And what is it they're afraid of, and how would you go after it?
Okay, I'm going to pass it to Alain, because I'm sure you've dealt with this scenario or scenarios like this in the past as well.
Yeah, we have seen, well, not exactly that situation, but related situation. Well, my first remark would be to say that before genetics, this situation would have probably will have not occurred.
Okay.
Except that at that time the prognosis of the transplantation was not the same. So it's a kind of a paradox of the advances in genetics. I fully agree with the previous comments that the term variant of unknown significance should not be used, I would say. And we try to explain to the family in different ways that the variant or the mutation has never been observed, but that because of argument 1, 2, 3, 4, we think this patient has indeed the Aldrich syndrome disease. And so we have to keep trying to explain the family why is it so. But of course, in any way, we can't force them to go to transplantation. We are not the police, and this would be completely
okay. So let me.
Could you? It would be stupid, because even if the right of the child is to be transplanted, likely in this context, there is no way you can perform a transplantation without the support of the parents.
Yes.
So we have to convince the parents in any possible way that this variant of unknown significance has actually a significance.
So let me just push this. So this child, let's say the variant is a pathogenic variant. You know it's a pathogenic variant. You know the child has got a clinical severe form of Wiskott-Aldrich syndrome. Let's say you've done protein analysis and there's no protein there. So you're pretty convinced. The parents don't want to do a transplant on this child. But this child has a severe form of Wiskott-Aldrich syndrome. What do you do?
These are situations we have made for Wiskott or for other diseases. Unfortunately, I don't think we can't force the parents to have their child transplanted again, because here, of course, there is a conflict of interest, a conflict of rights. But at the end of the day, I think it's not possible to undergo a difficult medical procedure, life-risky procedure, without the full support of the parents. We need them to be with their child at the time of hospitalization and so on. So it's not possible, unfortunately, to me, to go ahead in this context.
Okay. Nahla.
Why can't the specialist be a social worker? Not me. I totally echo what has already been said. It's a case of revisiting again and clarifying and making sure that the child's right in the transplant is pursued. That's what I would go for. In discussing the case, I would mention, the meaning of this variant of unknown significance with a very likely pathogenic role. That has to be very well clarified, because that might be the source of worry.
Absolutely. Yeah.
So I think that could be a key to making this family, assimilate the idea of bone marrow transplantation better. And the role of the mother, I don't know where is she from all this. Again, that has to be addressed.
Yes, very important.
Okay.
John.
I would want to, from a family perspective and, supportive parents, I think Steve's point very well taken, that I work with families that have very difficult time deciphering medical terms and translating them into their very concrete world. And a thoughtful physician going through all of this again might be the breakthrough of understanding. At the same time, you might find that that they do understand it as well as possible, and that their decision is to continue to not make a decision. And
is that okay?
Well, I would say it's okay in a case like this, because the treatments being suggested have sufficient risk that this is not suggesting a diagnosis of diabetes and a successful treatment with insulin could change this child's quality of life with a rather high degree of certainty. I don't think this, if I were on the healthcare team, I don't think this would raise to do I report this family to Child Protective Services or whatever they're not refusing treatment that obviously would help. They're refusing treatment that potentially could help but is risky. And I don't even know for sure they're refusing the treatment. Okay. I just know they're avoiding.
They are avoiding. Okay. There.
I'm concerned that they are not coming back for their follow-up, and how am I going to find them? It's very well saying we're going to talk to them if they are not turning up for their appointments. And my concern would be really trying to initiate a dialogue with the patient and trying to figure out how I can actually get them into a room with the clinicians to actually have a conversation and what the concerns are there. They are obviously interested in having their child know what's going on with their child, but they are obviously very scared of getting then the diagnosis given because they've toured through Europe. So really getting them to actually communicate with them and to come for the second appointment, and how can I facilitate that?
Because there is a risk to a child here, and let's just say even that it's not necessarily about transplant, but just getting them to have counselling with the specialist centres. Do you contact childcare here to try and find that family through various kind of social means, etc., in order so that the child gets the best care possible? Because it looks like this child is not getting the appropriate care because the family have kind of not going to the specialist centres.
Like everybody else, I would be concerned of immediately contacting childcare. I would really do my utmost best to get in contact with them, to befriend them. If there comes a point, I don't know, after 65,000 telephone calls, and I really have the feeling it doesn't work anymore, then further action would need to, because there is a child at risk, and there is a harm to the child, so therefore I need, within the team, not I, within the team, there would need to be a discussion where we are going from here.
Because at this point, what is your duty of care to that child to do the utmost you can to make sure that child gets the attention? And even if it's not, it's initially about a kind of counselling process rather than undertaking a procedure.
But you don't want to alienate the patients in the process of doing that. You really want to have the patients on board, as echoed by everybody else. And I think it is important to start a dialogue, to start a telephone conversation, to start an email thread, however they are willing to initiate a conversation with you.
Okay, James.
I take it everybody's noticed, but after just 2 cases, they've taken the microphone away from me. So, initially when I encountered this case, I thought that the answer would be relatively straightforward, but it seems to be a problem with the father's education, but his misunderstanding what unknown significance means, and that if only we could, as Theo suggests, have 65,000 telephone calls and talk with a family and explain exactly what the situation is, then because it seems clear that they're not, as John puts it, refusing treatment, they're just trying to avoid treatment. This is a family who really does want the best medical treatment for their child, and once they understand what the situation is, then they might start to go along and cooperate with their healthcare providers. But I think John noted something which is ethically important here, that the treatment is not going to be risk-free. It looks like this is going to be a risky treatment. So it might be that the father isn't simply misunderstanding what the situation is, which could be corrected through appropriate education and counselling and dialogue. It might be that the father has different values, or the family has different values than the healthcare professionals that are attending them. They might be much more risk-averse than the healthcare professionals, and so this might not be a factual disagreement, but a value disagreement. And what we would have to do, presumably, is to educate them into the respective risks and benefits of the treatment. But I think that once we've had that second type of education, we explain what unknown significance means, we explain the risks and benefits, maybe even introducing them to persons who've undergone the treatment successfully to show what could be achieved, then I think that the final decision is going to have to lie with the parents. And the disagreement then would be over the respective risks and benefits and how much risk the parents are willing to take on.
Okay, comments? There's one right at the back there. Anybody else before we get there?
Good morning. I'm Filmin Haring from Ghent University Hospital. We had a similar case, maybe it is the case, I don't know, but we had a similar situation. We could prove that there was no functional expression of the protein, so it was 0. We were happy to show that to the father. The mother was involved in the story. She agreed for the transplant. The father was not, although we could show no expression of the WAS protein. And then we had several discussions with the parents, but also with the general physician, with the pediatrician who had a good contact with the father. And finally, after 6 to 9 months of discussions, and the patient was admitted at the hospital, transfusion dependent, severe infection. At that time, indeed, this was one of the suggestions of the panel. We contacted childcare, and after many discussions and support of many team leaders, we decided to put the child out of the parental authority. Right. And we were a little bit upset that, okay, the parents, they agreed for that. And in this situation, the patient is admitted for transplant, and also the parents, they are out of their parental authority, but they are still involved, they are still coming to visit the patient, and nowadays we have the feeling that they are feeling comfortable with that. So what's the message of a similar case as this case presented here is that yes, we as a specialist, we are very important to take care of these children because these are children at risk. But you cannot do this alone. You need to have a whole team together to discuss with several authorities and also social persons who are involved in this case. So you need to keep on going further to help this child because the child is the most important person in this situation.
Thank you very much, and that's fantastic that we have a kind of real-life example of this. So that is kind of slightly at odds with what the panel have said. I mean, the panel have said, look, we give them all the responses, we give them all the information. Yes, this child needs a transplant, but there's probably a 5 to 10% risk of mortality associated with the procedure. So if the parents say no, then we shouldn't do it. But actually, what the physicians here have done is felt that their duty of care is to the child, and they've taken that child out of parental responsibility and undertaken a transplant. So what do you think about that?
I would like to say one important thing I heard is going back to the primary care, to the local physician who knew the family. That's one way to ethically address what's really going on with the family, what needs to be done, and go to the person the family most trusts, perhaps.
But in the end, they still had to take the child out of parental responsibility to do
But the order that they did it, I think, is
no,
very
I fully support. No, sure.
Yeah.
So, James.
Just a quick question. Were the parents in opposition to having the child taken out of their responsibility? Because it might be the case. I can see some parents not wishing to make the decision.
Yeah. Right.
And wanting to have the child get the best care, but wanting it to be medical personnel who make the decision. And a clear way of doing this is to take the child out of the parental responsibility, and then the parents, the burden is taken off them, and then they can start cooperating. So was that what happened in this situation?
Okay, so as I expressed already, so we involved really the role of the general physician, of the pediatrician, and it took us a long time to convince the parents. Okay, to be honest, we said, okay, if you don't agree, we need to take some other steps because this is very dangerous for the child. And also we felt that the mother, she agreed, but there was also some ethical and social problems and also some relational problems. And afterwards the father agreed that this is also difficult, that he has psychiatric problems. And in this situation, all these situations together, but it took us a long time, then we could convince that there is no other possibility than to take this decision. And it's very strange, but last week the whole team received some presents from the father to thank everyone. So, but it's important to involve all the people. There was one pediatrician that he trusted, and we involved that pediatrician in this discussion, yes.
Okay, all right, there's one, I think, Colin, you wanted to say something.
So in my center, we do a conjoint clinic with bone marrow transplant. So it's us and the transplant team, and we see all of our patients together. which helps because they're hearing it from the immunologist, they're hearing from the transplant team, they're getting the same information all at once. And we've actually had this in 2 different scenarios. And one, we've been talking to the family for over a year now, and they have finally agreed to transplant. But as we got to talking to them more and more, we found that a family member had had a bone marrow transplant and died, did not have a good outcome and died a very horrific death. And that was their reason, because their mind, she's healthy now, if we transplant her, she might die. And we don't want to do that. We'd rather her be healthy. Well, now as she's getting sicker, they realize they really do need transplant, and we are going forward. And then with our other patient, we had a mom who said, I would agree to transplant, but it's God's plan. So if God wants her to be healthy, God will cure her. And this went on, and the child got very, very sick, was in hospital for months. And we actually, both the immunologist and the bone marrow, we went to the ethics committee, and the child was removed from the home, put in foster care.
Okay.
And she's actually doing well, and now her parents are involved again.
Okay, all right, thank you. I think we're going to leave it there. We're just out of time. So at the end, I'd just like to say thank you very, very much to all the panelists, for those who put forward the question. I think it's been a really interesting debate, and thank you all for your participation as well. So thank you.